This video is really going to be concerned with milestones in infant development. These are issues that are important to all orientation and mobility specialists who work with very young children. We know the techniques that work for ambulatory children and for adults, and probably even more important, we know the goals that we set for all of our students, and so we know how to get from point A to point B when we start working with an ambulatory child or an adult. But oftentimes, we're also called upon to assist with the development of the infant and sometimes also the toddler, and that's in regard to their pre-mobility activities. So we're often going to take on the role of a consultant where we'll be working with the parents, with the caregivers, with the teachers, and then also we'll often be called in to work periodically with the child. And so it's important that we have a good foundation in some of the basics that lead up to independent mobility. So let's start with pre-crawling. The child starts reaching out for an object when he or she is on all fours, and that's the first step towards crawling, reaching out with the arm. Also, moving from or to a sitting position is also a precursor to actually crawling. But there are certain foundations that are needed in order to crawl. First of all, there has to be postural stability, where the center of gravity is basically centered around the hips rather than higher up near the head and the shoulders. Another foundation is the ability to laterally shift the weight so that one free hand can reach forward. And then a third possible foundation that is often needed is trunk rotation, the ability to shift weight from side to side and rotate the trunk. Now, some visually impaired children are delayed in their crawling, and some visually impaired children bypass crawling altogether and go right into walking. Oftentimes, it's a lack of postural stability that is the cause for delay or a bypassing, and it may be due to a lack of active experience when the child was in the prone position and didn't go through a prone progression. So let's talk a little bit more about prone progression. Well, first of all, experience in the prone position is needed. Play in the prone position is needed for the development of the extensor muscles of the back, which allow the shifting of the center of gravity from the upper portion of the body, from the head and the shoulders, to the hips. And it's stability at the hips that allows the shifting of the weight to one side, which ultimately frees the other side and the arm to move forward. Now, some visually impaired children compensate for the lack of stability at the hips by taking their heads and placing them on the floor while they're on all fours to free up one hand and to be able to move forward. But there are certain steps that are necessary in prone progression if the child is going to be learning to crawl. So first of all, we have to start in the prone position. There has to be enough experience in that position. Children don't always like that, and we may have to introduce it briefly, but we need to have enough experience in that prone position. Second, the child then needs to learn to elevate their head while they're in that prone position, and that builds the muscles that are necessary. Then they have to be in the prone position with their head and their chest elevated, so pushing up with their chest. And then the next step is providing support on their forearms, followed by providing support on the forearms and starting to reach. The next step in that prone position is with an extended arm that is weight bearing. So pushing and still maintaining weight bearing, and then being able to pivot in that prone position. So the development of crawling. Blind infants may rock back and forth longer than sighted children on all fours before they actually start to crawl. Sighted children do rock back and forth as well, but they don't do it for as long as blind children. Sighted children will rock forward of their extended arms, going a little beyond their arms, while instead blind children keep their movement up to but not beyond their extended arms. They're more confined to within their base of support. And the slower development in this area may be due to blind infants reaching objects at a later period in time than sighted children do. They are reaching for objects that emit sound, and that may not start as early as for sighted children who are reaching for what they see. Some of the movements, interestingly, in blind children may really relate to the protection of their head. So I have seen this, and many O&M specialists report this, that blind children may have a tendency to crawl backwards for several weeks before they actually begin crawling forward. And some will scoot forward in a sitting position when they're in an unfamiliar environment so that their feet can detect obstacles. So this makes perfect sense because the head is very vulnerable, and if you crawl forward with your feet or scoot forward with your feet, you're protecting your head. So we have to look at interventions, and an intervention that promotes play and movement in the prone position early on will facilitate the prone progression that we've talked about. And reaching in the prone position while being on all fours really should be emphasized, giving the child something to reach for when they're in that all four position, developing muscles and doing just that. The transition movement intervention activities that really can help very early on with the very young infant. These are things that we can talk to parents about and can really help develop the child. During diaper changing, the parent or the caregiver places the infant in a prone position first and then slowly rolls the infant into a supine position. And that's building muscles and demonstrating what the movement is. Another thing that can help is the way the infant's picked up. For infants that are sitting, when they're being picked up, if the caregiver can help the infant to weight bear with both hands on one side while they're being picked up, and then roll over to all four before being picked up, that again is introducing that movement, building some strength, and demonstrating what needs to be done. In regard to infants that are standing, just starting to stand, rather than placing the infant in a standing position in front of something where they want to play, if the parent or the caregiver can place the infant on all fours, or maybe close to that object, maybe close to the sofa or wherever, a coffee table, and help the child to reach up with one hand and kind of demonstrate, modeling, moving the child to kind of a kneeling position and then moving to a standing position. That eventually will help and will build. So those transition movements can be very helpful. Let's talk a little bit about walking. Most children start to walk independently anywhere from 10 months to 15 months, and very, very quickly they become independent walkers. Once they take a few steps, it doesn't take long at all before they're really walking. Now, blind children may take a few steps with their hands being held and with somebody holding them, and that occurs sometimes by the end of the first year. However, they show delays in taking independent steps. The median age of attainment of walking without support, and when I say without support, I'm talking about with the ability to walk at least 10 feet, is generally about 18 months. So it's a longer period. And children with visual impairment and other disabilities tend to walk without support. It may take them as long as 26 months. So these are norms that you should be familiar with. Parents certainly are going to ask about this and wonder if their children are abnormal. So children with sight often go through a stage of cruising. I'm sorry, children without sight go through a stage of cruising before they start independent walking. Oftentimes what we'll see is they walk sideways along furniture and along walls, and they'll use one or two hands for support as they're moving along. Now this has a lot of benefits for kids that are visually impaired. It does a number of things. It provides them with hands-on experience with some common objects and landmarks that they might find. It helps them develop the beginning of a mental map. It gives them a chance to practice mobility, upright mobility, before they may be posturally ready, but it gives them help in doing that. And it also helps them in preparing for trailing, because really they're trailing with one or two hands as they're cruising along. So it's a normal stage, and it's something that's very helpful. Stairs present their own problems. They're a real challenge for infants that have no sight. The child, though, will benefit if they're closely supervised and allowed to crawl up and down, single steps, multiple steps, gives them good experience, good practice. And if they're crawling down the stairs, they should be crawling down feet first to prevent really tumbling head over. And this gives them good experience as well in preparing them later for walking up and down the stairs. It builds upper body strength. It provides for fine motor skills. And it increases their tactual discrimination. Now, kids that have low vision oftentimes have difficulty judging the depth of something that they're encountering. The depth change becomes a problem. And that can be due to reduced visual acuity. It could be because they don't have binocular vision. It could be because they have a lower field loss. But that's something that we have to be aware of. In a short while, I'll show you an example of how kids do climb up and down stairs when they're visually impaired. But in the meantime, let's talk about goal-directed movement. After the child starts walking, it's important to develop individually designed what we're going to call micro routes. And these are very, very short routes that lead children to meaningful landmarks and locations that are important to them, and it helps reinforce goal-directed behavior that will continue on and will increase with time. And so for regular everyday activities, going to the bath, going to lunch, going to playtime, helping with establishing a mini route, something that's short, that gets the child moving. And it should start with using trailing, not walking freely in the open, but trailing a surface. And it doesn't have to be a long route. In fact, if a child is only taking one or two steps at a time, the route could only be one or two steps. Rather than taking the child right to the high chair at lunchtime, take the child close to the high chair where it's one or two steps away and have the child walk to that chair or move to that chair. Backward chaining can eventually be used where you start very, very close And little by little, you move the child a little farther back and a little farther back until it really increases their ability to walk. Okay, as far as the experience on stairs, take a look at this clip.
In this clip, Austin and the OMS are shown at the landing halfway
The
up the
orientation and
stairs.
mobility specialist is
The
helping the
OMS
child
is
as the
shadowing
child is
Austin
crawling
and
up the
encouraging him
stairs.
to climb to the top of the stairs. He crawls away from her to the opposite wall, stands up,
And you can see that
and
this
cruises
child
along the
is
wall
starting to
until he
stand
reaches the next step. Then he scoots up the stairs on all
and is really
fours.
making a dash up those stairs.
At the top, he stops and appears to be shaking his head to say no. He pauses and puts his head on the floor and then moves over to the railing on the left where
Looks like he's
sunlight is
resting for a
flowing
minute.
through a window onto the landing at the top of the stairs. Then Austin is shown backing
Now he's
down the
heading
steps
back
on
down,
hands and
and the
knees with
specialist is
tactile
guiding him.
cues and encouragement from the OMS. Austin moves down one step with
Feet
the
first.
OMS providing support to his pelvis. He moves over to the banister on his right, pulls up while holding two spindles about 18 inches apart, and peers over into the foyer and family room
Now he's
of
up.
the house. He gazes over to the OMS at one point, and she seems to encourage him to move back up the stairs. He places his left knee on the step above him and pulls himself up using his arms. Then he moves to standing and appears ready to step up to the next step while holding onto the spindles with both hands. Instead, he turns into the OMS's arms. Finally, Austin is shown backing down the last four steps near the foyer with the OMS on his right. She coaxes him down while holding her arms out so that she can catch him if needed.
Specialist is there to catch him.
Austin's mother is on his left, and she appears to be encouraging him to crawl down to her. After he reaches the bottom, he steps across to his mother, who gives him a hug.
He's running to his mom. Okay, so that is an example of climbing up and going back down the stairs. Next, and finally, I want to talk a little bit about developing fine motor skills. We know that a grasp reflex usually is found right at birth, and it happens when a thin object is placed in the hand and the infant's fingers close around the object. You curl around the object. Now, someplace between 1 and 4 months, that reflex integrates into more of a voluntary control of the hand. And within the next 2 years, hand skills become much more precise, and they include picking up smaller objects and using specific finger motions. For example, they can poke their brothers and sisters with one finger. At 5 months, sighted children show coordinated function of hand and eye movements by reaching and grabbing an object. But without vision, there's really no incentive to bring the hands within visual range, even to move it towards the midline or to move them together. Also, if children have low tone, they probably will have reduced proprioception, and they may not even understand exactly where the hands and arms are located in space. So interventions sometimes will need to be provided, and they should include some of the following activities to facilitate awareness of the hands and where the midline is located. Helping the infants find their hands, facilitating hand-to-hand play and moving the hands towards the midline, facilitating development of grasp, hand-to-mouth play, hand-to-foot play, just getting to know what the hands are capable of doing. So these are all activities that will be helpful to the parents, and as an O&M specialist, you'll at times be called upon to work with parents, reassure them that their child is making good progress, or help them if their child needs transition exercises or other activities. And certainly you want to do all of this in combination with an OT or a PT.